After those wonderful talks on the clinical manifestations of ocular surface tumors, both stromal as well as epithelial, I'll be speaking on the management of ocular surface tumors. Now, imaging is very important in ocular surface tumors because oncological principles always mean that you excise the entire tumor. Otherwise, you have a higher chance of local tumor recurrence. While edge is easily determinable on clinical evaluation, a good slit lamp evaluation will tell you about the edge. How do you know the base? Base is something that is always a suspect. Slit lamp will not tell you very clearly about the base because you cannot see through the tumor many a time. Then comes the role of imaging. Of course, anterior segment OCT has some disadvantages because in the areas of keratin there is some shadowing. You'll still be able to estimate the depth of the lesion. Of course, diagnosis is also part of it. This is a beautiful picture where you can actually see the level of the lesion very clearly. You can see that conjunctiva is involved, this bubbly layer is the tenons. So your plane of dissection can just be there, episclerals. You don't have to do anything in terms of deeper dissection. So you know the plane of the tumor. And in this patient, there is full thickness corneal stromal involvement, which means that you have to either consider a penetrating keratoplasty or plaque brachytherapy. So depth of the lesion can be determined by either anterior segment OCT or UBM. All these patients have had UBM mainly because we suspected intraocular extension, which they all have. That doesn't mean that you enucleate them, you can always plaque them. Now, coming to the most important modality of managing epithelial tumors, topical therapy, topical chemotherapy or immunotherapy. Mitomycin and 5-fluorouracil are chemotherapeutic drugs. Both are extremely useful, have been used over a long period of time in the management of ocular surface tumors. What is relatively new is interferon alpha-2b, which is immunotherapy. In between that is a specific use of cidofovir, which is hardly ever used. These are very specific cases of OSSM with HIV positivity where cidofovir is used. Indications I'll show you in pictures, but before that, if you want to have a head-to-head cost comparison, 5FU is least expensive. If you want to know which is the most effective drug, mitomycin. It is the most effective drug, but it's also not friendly to the ocular surface, causes corneal epithelial erosion, chronic conjunctivitis. Many patients are not able to tolerate it. Most friendly drug is interferon, but it takes time to work. So this is the fastest drug. This comes somewhere in between in terms of its effect and complications. This is the slowest drug, very gentle to the ocular surface. It has hardly any complications. Now, there are three ways in which interferon can be used. One is immunotherapy, where your endpoint is complete resolution of the tumor. That is your endpoint. So you clinically determine which tumors are going to behave in a way that they completely resolve. I'll show you how to do that. Immunoreduction is a principle where, just like retinoblastoma, where you take a large tumor and shrink it down and then apply focal therapeutic measures. This is a way of reducing the size of the tumor so that you can do a minimal surgery instead of an extensive surgery. Immunomodulation is a relatively new concept where you modulate the ocular surface immunity to prevent new tumors from happening. This is so in patients who are immunocompromised or xeroderma pigmentosa patients where they crop up new tumors every now and again, they are prevented by using immunotherapy. Now, this is a small tumor. This tumor has completely gone away with topical interferon. This is a very clear indication for topical therapy. Small tumors which are not really surgical candidates. Of course, if a patient wants a one-time cure, you can offer surgery for this patient. Another small tumor resolved with interferon. It takes about 4 to 6 weeks for small tumors. This was a patient who was excised earlier, has recurred, and that was again managed with topical mitomycin C. So recurrences where you already know the histopath. The most important indications for topical therapy is corneal OSSN. This is a patient, this is my favorite slide. My cornea specialist had done a biopsy here. Rest of the tumor was taken care by topical therapy. 3 years later, you can see corneal scar exactly in the area where he had done a biopsy, which means that there would be some subtle corneal scar if it were to be surgically primarily excised in the pupillary axis, thus precluding 20/20 N6 vision or whatever vision that the patient is capable of. So corneal OSSN, if you want minimal scarring or no scarring and good resolution, the treatment of choice is topical therapy. Surgery is secondary. This is a very clear indication for topical therapy. Now, this was a patient who had xeroderma pigmentosum. Other eye is lost already, and this is a third graft that the patient has. And exactly in the graft host junction, there is a OSSN. So this is not a surgical candidate because even a minor surgical intervention here may tip the graft in favor of, say, graft rejection or failure. Here again we use topical therapy. The graft has become clear again, DM folds are gone, and the tumor is completely resolved. So one clear indication. Next indication is limbal extent of the tumor. Limbal extent, because if the patient has more than 6 clock hours of limbal invasion, then possibly there is going to be limbal stem cell deficiency when you excise these tumors primarily, right? So if you want to prevent that complication, then you use topical therapy. You can see a scarless healing there, limbal stem cell barrier is absolutely fine. Next indication is diffuse OSSN. If the configuration of the tumor is like that, flat, placoid, rather than elevated nodular, this is very clear indication for topical therapy. It works most effectively when there is corneal OSSN, when there is flat tumor, like this. So this took only about 3 months for the tumor to go away without any stigma of any surgical intervention, scarless healing. Next is extensive tumor. Extensive tumor where only surgery that you can do is orbital exentration. You can offer them topical therapy in such patients. This is of course not 100% successful. Maybe half the patients will resolve with this. This is a patient who had palpebral as well as bulbar conjunctival involvement and resolved with injection interferon. So you bring in injection interferon when the tumor is more extensive and resistant to topical therapy. Clinically, you feel that it may not respond to topical therapy. Then you inject interferon, which is 3 to 10 million international units every 3 weekly for about 3 to 6 injections. After that, you decide whether you want to do any further surgery or not. HIV positive patient, diffuse OSSN, resolved with injection interferon. So injection interferon is a reality and it can be used judiciously in patients who deserve it. Whereas interferon is used as an injectable, mitomycin and 5-fluorouracil are only topical drops and they should not be used in injectable mode. Now, immunoreduction is a principle. For example, if this is the tumor, that is the epicenter of the tumor. You know that OSSN is a tumor of the limbal stem cell. Around it would be a zone of carcinoma in situ, severe, moderate, and mild dysplasia. So what topical therapy does is it does not work on infiltrative tumor, but it works on all else, carcinoma in situ and dysplasia, and what is left ultimately is the invasive component. So all that is left is this now for you to excise from a large tumor that you started off with. So you reduce the tumor and then shrink it down to the size that you can do minimal surgery. Immunomodulation is performed mainly for patients who have immunosuppression, either iatrogenic immunosuppression post-organ transplant patients or HIV positive patients, or for patients who have xeroderma pigmentosum. The next is about topical chemotherapy, case selection. These are the advantages and disadvantages. I won't elaborate on that, but mainly topical therapy sometimes can turn out to be more extensive than one-time surgery. That you have to keep in mind, and also the compliance of the patient in terms of using the drop. Otherwise, it's not a good idea. When not to offer topical therapy, when the diagnosis is in doubt. You haven't been able to diagnose it clinically, but you still use topical therapy, that is not acceptable. Example is this patient who looked like this. Many of you would say that it is OSSN, but when you flip the lid, you realize that the lid margin is affected and posterior lid margin is rounded. Meibomian gland orifices are all lost, indicating that it is pegytoid sebaceous gland carcinoma, which is not a candidate at all for topical therapy. Now, this we covered already. When you're not sure about the depth, again, topical therapy should not be used. You should definitely make sure that there is no scleral or corneal infiltration before you start off on topical therapy. And when you're not sure about the stage, some of the articles generalize. For example, this article from a very nice group, what is written is 85% of T3 tumors respond to topical therapy. When you look at what is T3, AJCC, tumors that invade cornea, intraocular structures, pharyngeal conjunctiva, palpebral conjunctiva, tarsal conjunctiva, punctum, canaliculi, etc. are T3. How would that respond, right? So just by looking at the abstract of an article, you should not start on topical therapy. These are advanced cases. They should not be started on topical therapy. Example is this patient where somebody started on topical therapy and the tumor promptly increased in size despite being on topical therapy. This was not a good candidate. And when you're not sure about patient compliance and a patient comes with a small localized tumor like this, obviously you can simply remove it with a 10-minute surgery. Why not give this patient 3 months worth of topical therapy? So patient unlikely to be compliant, has a small tumor, again you remove it. Adjuvant therapy should not be guided by guess. Many times I get consultations saying that, okay, I've removed the tumor, should I give topical mitomycin? So why should you give it? There has to be a reason. Only if the resection edge is positive and that contains only dysplasia and carcinoma in situ. If you have already done edge cryotherapy, only observation. If you have not done edge cryotherapy, then topical chemotherapy only for dysplasia and carcinoma in situ. If the resection edge is positive with invasive squamous cell carcinoma, medico-legally you are bound to re-excise it. Otherwise, you cannot rely on topical therapy for an invasive squamous cell carcinoma. We know that already. If resection base is positive and if the pathologist can localize the particular claw cover of the base, then cryotherapy is a possibility. But if resection base is diffusely positive, then you have to resort to plaque brachytherapy. Let's go to surgery. Surgery, the most important concept is excision with tumor-free margins and tumor-free base. Margins clinically determined plus histopathologically confirmed, base determined by imaging and histopathologically confirmed. For the corneal epithelial component, use alcohol-assisted keratoepitheliectomy. Cryotherapy to the resection edge is mandatory. Every patient gets it. This is a kind of diagram we have to make and take to the OT or take digital photographs. Every detail mentioned, so that slit lamp diagram is the best. Once you give peribulbar block, sometimes there is conjunctival effusion resulting in poor definition of the tumor. This is a very straightforward surgery where you mark the edge of the tumor beyond 4 mm from the clinically determined margin. That means that you would have already done Rose Bengal staining to determine the extent of the tumor beyond that 4 mm margin. Then edge is excised using either a monopolar electrode or any surgical instrument of your choice. This is surgeon specific. Excision of the tumor, again from the base using, I use RF because I'm used to it for oculoplasty surgeries. I use the same instrument. Cauterize blood vessels paralimbally so that there is minimal bleeding. Apply alcohol to the leading edge of the tumor about 3 to 4 mm beyond the edge of the tumor so that the epithelium becomes loose. This is to preserve the Bowman's membrane so that you don't have to do dissection between the epithelium and the Bowman's. Epithelium becomes loose and you can simply scroll it off towards the limbus. We have already reached the limbus from the scleral side. Now we are reaching the limbus from the corneal side. OSSN is a tumor of the limbal stem cells. Then you have to finally excise it off the limbus under visualization. So these steps are followed in all patients. Then you excise it simply off the limbus under visualization. I use a wet technique. Even if you want to use a dry technique, that will be wet with blood anyway. It's best to see the base of the tumor when you excise it. That's the excision edge cryotherapy, where you wrap the edge of the tumor in a reverse fashion on top of a 3 mm cryoprobe and freeze it twice and thaw it spontaneously. This gives you an additional 3 to 4 mm clearance from the excised edge. Subclinical tumor will be taken care of by this modality. If you don't do it, then there is a higher chance of local tumor recurrence. Resection base cryotherapy is not mandatory, but if you clinically see that, okay, base is slightly deeper at 1 or 2 particular claw covers, you can always do that. More than 3 claw covers of limbal cryo is not recommended. You should then wait for histopathology, and if base is positive, you should do plaque brachytherapy. Then how to repair the ocular surface is again surgeon choice. You can either use a conjunctival autograft from the same eye or the other eye if the patient permits, or use an amniotic membrane. We use a glued on amniotic membrane, which is very nice for the patient because there are no stitches, there is no irritation, and there is very good resurfacing of the ocular surface. Patients do well following surgery, and if you use OCT guided surgery, then you can actually predict the depth of the lesion. Now, what is relatively new is the use of primary simple limbal epithelial transplantation in patients who have extensive tumors so that there is minimal complication of limbal stem cell deficiency. Surgery does remain an excellent choice. I have already spoken about adjuvant therapy. Let's see what are the cases which are beyond surgery. Patients who have tumors which are affecting the corneal stroma or sclera cannot be managed by surgery alone. They need something beyond surgery, and that is plaque brachytherapy. So plaque can be done secondarily or primarily. Secondarily, when you excise this tumor, confirm it on histopathology that the base is involved, and then to that base you apply plaque after epithelialization is complete after 3 to 6 weeks. That's one way of doing it. That is what has been done in all these patients. They have been doing well. And the second is to do primary plaque brachytherapy, specifically in patients who cannot stand a surgery. Why they cannot stand a surgery? Because you can see that there is already stromal melt. We don't know how healthy is the base here. We may actually have a limbal perforation which cannot be repaired. Patient may have intraocular extension. Then you do a primary plaque brachytherapy. Primary plaque brachytherapy is again a reality where you apply the plaque right on top of the tumor, either at primary surgery or even without doing surgery. Plaque has excellent success to the tune of about 90%. Now, there are very rare situations when there are advanced tumors. This young individual had multiple surgeries and had intraocular extension. He was referred for possible eye salvage. He was very keen on eye salvage. He had reasonable vision. The tumor, which had intraocular extension, was on the nasal side. His temporal retina was fine. His disc was fine. This is the kind of nasal retinal detachment he had. He had choroidal extension of the tumor, and he wanted to preserve the eye. He was very young, and we thought we would give it a try because OSS is a safe tumor. It doesn't metastasize so much. So we designed a radiotherapy field for him. We gave what is called chemoradiation, where he was injected cisplatin and given radiation at the same time. And after some time, you can see that retinal detachment has settled and his choroidal component has completely reduced and ciliary body component has also resolved, and it's remained so till date. So these are some of the innovative therapies which can be used for extensive tumors. Now this is a patient with conjunctival melanoma, diffuse melanoma with, you can see, intraocular extension. These are the ciliary processes that you see. This patient also had good vision and he wanted to preserve his eye. So I'll skip the video. Basically, we excised this and then did what is called rotational plaque brachytherapy. So plaque was applied here, there, and there. So plaque has a particular dimension, so you have to repeatedly apply it to cover the entire base of the tumor. And this was at the last follow-up. He is doing very well. Vaporization of conjunctival tumors for lymphangioma, where you already know the diagnosis. Bleomycin is a possibility, but instead of using bleomycin so close to the cornea, you can always use vaporization technique. And target therapy is the last bit. This is a patient with conjunctival lymphoma with posterior extension along the surface of the eyeball beyond the equator. One option is to do radiation for the residual tumor, but here we choose perilesional rituximab, 5 mg per ml, 6 injections, 3 weekly, actually cleared the tumor. For conjunctival melanoma, we have the mutation and the treatment spectrum all worked out. There are many reports in the literature using pembrolizumab and nivolumab. This was our own patient where the patient had regional lymph node metastasis, for which we started on nivolumab. He was admissible for nivolumab, and regional lymph node metastasis obviously started regressing, and his conjunctival melanoma also started regressing. So making a role for primary therapy of conjunctival melanoma with target therapy. So in conclusion, I would say that there are rapid new strides and paradigm changes in the management of ocular surface tumors. What is important is good clinical evaluation and imaging to determine the edge and base of the lesion. Then you decide if a particular patient is appropriate for topical therapy, whether it is interferon, 5-FU or mitomycin, depending on the patient profile and the ocular surface health, and or for primary surgery. When you do primary surgery, it is mandatory that you take care of edge as well as base clearance. Use histopathology as the guideline for adjuvant therapy, if any. That will give you much better outcomes. Thank you so much.